Hello everyone. It's a beautiful Sunday. The sun is shining. The COVID is disappearing, and things are coming back to normal. So, webinar on this topic of how to avoid or delay recurrence of prostate cancer after initial treatment. So I'll, of course, like to thank Helen and the Sunway Group, and I also like to thank all of you guys who have posted questions. And I will try to answer these questions after my talk. So prostate cancer, as you know, in the majority of patients, is a very slow-growing disease, which takes years to progress. So the journey for a prostate cancer patient is not a 100-meter sprint against time. Right. So as I said, the journey that a prostate cancer survivor takes is like a long sea voyage. And of course, each patient's journey is going to be different, depending on, of course, the type of prostate cancer that you had when you started your journey. Was it a Gleason 6? Was it a Gleason 7? Was it an 8? Was it a 9? Was it a 10? So the course of your journey will depend on which boat you are in when you first started this journey. If you happen to be in the low-risk boat, all the patients who sit in this low-risk boat, which means Gleason 6, of course, your chance that the cancer comes back is much less than if you are in the intermediate risk boat, which is the Gleason 7 guys, or if you are in the high risk boat, which is the Gleason 8, 9, and 10 guys. So the risk of cancer recurrence will vary from something like maybe less than 5% in these guys to about, say, 30% in these guys and to about 50% in these guys. Okay? So all cancer survivors are always looking for that magic bullet that will prevent or delay cancer recurrence. However, at the moment, we don't have this magic bullet yet. So until we find this magic bullet, your best bet to slow down cancer recurrence is actually to invest in a comprehensive lifestyle program. This program just consists of 3 basic pillars: the diet, the physical and mental activity, and to achieve a healthy body weight. If you look at all the international prostate cancer guidelines all over the world, whether you look at the American guidelines, European guidelines, Australian guidelines, all of them emphasize the importance of a balanced diet. Balance means no single food can prevent cancer, but the right combination may help make a difference. So the balance should be like this. One, if you look at your plate, you divide your plate properly. Don't put everything in there. If you divide it properly, 1/4 should be protein, 1/4 starch, and 1/2 vegetable and fruits. And you should try and stick to 3 meals a day. Try not to have snacks in between. So we have to replace our favorite foods. I'm sure all of you have these favorite foods that you indulge in from time to time. So we should try and replace this kind of diet that we're used to with this kind of diet. And this diet is actually what is recommended by the Malaysian health authorities. They call it suku style. It means suku means quarter, half. Quarter is starch, quarter is protein, and half is vegetable and fruit. Okay, so let's take the protein part first. The protein part first. So protein, the best kind of protein is actually white meat. White meat means chicken without skin or fish. And I'm sure a lot of us also enjoy our red meat, beef, lamb, and pork. Just try and reduce the pork portion. Reduce it to about 500 grams of cooked red meat. Those cannot eat, just try and reduce it. And of course, avoid all these processed meats. Processed meats means hot dogs, burgers, and pizzas. These are really, really bad meats. And also, it's a good idea, say maybe once or twice a week, go for a vegan diet. Vegan diet is like a vegetarian diet, where all your protein is not from meat, but it's from plants. And this means beans, pulses, peas, and lentils, or eggs. So it doesn't mean you have to go to vegan diet. Maybe say once or twice a week. No animal meat. And also, the way you cook your meat is very important. Cooking methods like stewing and braising and steaming are far better than grilling, frying. Because we know when you use very high temperatures to cook your meat, you can form chemicals in the meat which may increase your risk of cancer. Next, let's take carbohydrates. Carbohydrates, of course, is our main energy source, and it helps to feel full in between meals. Now, in Asia, our staple carbohydrates, of course, white rice. But white rice is highly processed. It kind of rob you of all the vitamins. So it's much better if you can switch to unpolished rice, either brown rice or red rice. Now, in the West, Masalis, they don't take much rice. So most of their carbohydrates, most of their healthy carbohydrates comes from these kind of foods: whole grain, beans, fruits, vegetables. And so we also can, a lot of people now are trying to cut down on rice and switch their carbohydrates to these kind of complex foods. Of course, when it comes to anti-cancer, vegetables and fruits are the main anti-cancer stuff. The more color yet you have, the higher is the nutrient value of these vegetables and fruits. The cabbage family, which consists of these cruciferous vegetables, broccoli, cauliflower, cabbage, Brussels sprout, bok choy, and kale, these seem to have a very special, they seem to be included in prostate cancer. I don't know whether it's true, but these are what I recommended. And of course, the dark green leafy vegetables, mustard, lettuce, chicory, spinach, and chard. These also seem to have some anti-cancer properties as far as prostate cancer is concerned. Now, we also need some fat in our diet. But if you choose fat, try and keep it to this unsaturated fat. You can look at the food labels. Unsaturated fats means polyunsaturated or monounsaturated. Don't go for the fully saturated fat. So this healthy unsaturated fats, you can get it from a couple of sources. You can choose to get it from plant foods, and this includes olive oil, vegetable oil, palm oil, coconut oil, nuts and seeds, and flax seeds is a favorite in the West. Or you can opt to get this unsaturated fat from oily fish. Oily fish like salmon, mackerel, and sardines, they are a good source of omega-3 fatty acids, which are healthy unsaturated fat. If you, on the other hand, like dairy products, try and choose the low-fat dairy products. It will be written on the label, low-fat dairy products. So this is how our food pyramid should look like. We actually largely should base it on vegetables and fruits, and smaller portions of protein, smaller portions of fat, and smaller portions of starch. So this is how our food pyramid should look like. Now, the other thing is, another common kind of question is there any special diet for prostate cancer? And the answer is not yes or no, but maybe there are some diets which may be helpful in prostate cancer recovery. And of course, I'm sure you all know these things. Maybe the lycopenes from tomatoes, the lycopenes from jackfruit, these may be beneficial for patients with prostate cancer who are looking to try and reduce the recurrence. The other special food is phytoestrogens, and you get this mainly from soy products, tofu, tempeh, soybean drinks. And the other anti-cancer special food is curcumin, and you get this from turmeric. So if you think all these products are helpful, you can include them in your balanced diet. But the main thing is still the balanced diet. The balanced diet is the main pillar. All these things you just add on to the main diet. Now, what about vitamin supplements? Both the American Cancer Society and the American Institute for Cancer Research, both these people have emphasized the fact that vitamins from natural foods is vastly superior from getting them from supplements. So if you have a balanced diet which have all the vitamins, it is a much better source than take supplements. I'm not saying don't take supplements, but vitamins from natural foods is much, much better. For those of you who are interested in these alternative special foods, for example, you can see here, calcium, green tea, lycopenes, pomegranate, seed oil, vitamin D, vitamin E. I will refer you to this website. It's called the National Cancer Types of Special Food, and they give you the evidence for this. And of course, this is the doctor's page. You can click on this, go to the patient's version. So it will give you a more simplified kind of explanation, and they will tell you what is the evidence. Are these things really good? Are they just tested in animals and they've been tested in large cohort of patients? So now we go to the next pillar of this comprehensive lifestyle program. That is exercise. So exercise, there are two components. The first component is what we call aerobic activity. And this means jogging, walking, cycling, swimming, and you should do this at a minimum of 30 minutes, minimum. And you should do it at least 3 to 5 times a week. During this activity, you should sweat. You cannot go for a leisurely stroll and come back and don't sweat. That's not good. You must sweat. And for people who like to be more evident, they will have one of these Fitbit things. They will measure the heart rate. So this is a formula for what your target heart rate should be if you perform these kind of exercises. It should be 70% of your maximum heart rate. Your maximum heart rate is 220 minus your age. So if you're 65 years old and you put it in the formula, your target heart rate should be just something about 100 or 110. So if you do your aerobic activity, one of the big things, you can look at your pulse and see, have I reached my target heart rate? I walk slow, So that is aerobic activity, 3 to 5 times a week. Should be a minimum of 30 minutes. Now the second component of exercise is muscle strengthening. Muscle strengthening you can't do every day because you fatigue. Muscle strengthening, just do it maybe 2 times a week. I think that's more than enough. These are all the kind of exercises you should do. If you have free weights in the house, you can do that. The other thing is to buy one of these elastic bands. You can buy it from any of these sports shops. They're very easy to maintain because they don't take space. And you can do it anywhere. You can do it in your sitting room. You can do it while you're watching TV. And these elastic bands, they come with resistance. So as you get stronger and stronger, you can buy the bands which are higher and higher. During this COVID era, where there was a lockdown and you couldn't go out, people resorted to home exercises, which you can get through the Zoom, which you get through the YouTube. And these kind of home exercises are very cheap, very cost effective in terms of time and money. And I think it actually becomes the new norm, because these exercises you can download, keep it in your computer, choose your favorite exercise. And this is some of the exercises that I have on my computer. I've got some stretching exercises, I've got some Tai Chi kind of exercises, I've got weight training exercises. Some of the older patients who can't stand up and do exercises can actually sit down and do this exercise. So I try and do one of the exercises every day. I just kind of choose the video, switch on the video, and it takes about 40 minutes. I do it in my living room, and it's done. So it's very time efficient, very cost efficient. And the last pillar of this comprehensive lifetime program is trying to maintain a healthy body weight. BMI is your body mass index. It's your weight divided by height. This is what is ideal, 80 to 25. Of course, most of us can't get to the 80, but you should at least try and keep your body weight, your BMI, to 25. Anything more than 25 is considered obese. Anything over 30 is really pushing the limit. So you should try and keep your BMI somewhere in the 25. The other very important thing is waist circumference. Circumference, as you can see, is not down here. It's not where your belt line is. And you should try and keep your waist circumference at least less than 40 inches. So these are the two things to aim for. And how to get a healthy body weight is, of course, get a balanced diet like we discussed, and try and limit the total number per day. There are a lot of and it's very good to count your calorie intake. Help you to count your calorie intake. They're very, very good apps. And I've used them before, and I've asked my patients to use them also to decrease body weight. Now, everything that we've been discussing so far is nicely summarized by this 2019 recommendation by the Journal of Natural Medicine Journal in America. This is the official journal of the American Association of Naturopathic Physicians. So their guidelines very nicely summarize what we've been talking about. Don't smoke. lose weight if your BMI is more than 27. Exercise vigorously several days per week. Do something that makes you sweat. Eat lots of vegetables, particularly cruciferous vegetables. Eat more fish, vegetable fat, like nuts, vegetable oil, soya beans, avocados, flaxseed. Eat less of saturated fats. If you have to take fat, eat unsaturated fat. Take less carbohydrates, that means less starch. Drink coffee. Coffee also is one of the things that may decrease your risk of prostate cancer. And it says, doesn't matter what kind of coffee, is it regular or decaf. Limit consumption of eggs and poultry with skin. We said poultry without skin is good, but here he says don't take poultry with the skin because the skin has a lot of saturated fat. Limit whole milk consumption. As I mentioned, if you want to take dairy products, try and go for the low-fat dairy. And of course, limit consumption of refined grains like rice, sugars, processed meat, and high-fat dairy products. So their recommendations kind of really matches what we're talking about. To this comprehensive lifestyle program, you can add stress reduction. There are many stress reduction techniques: mindfulness, meditation, yoga, cognitive behavioral therapy. All these help reduce your stress levels. Least but not last but not least is good friends. Good friends and support is very, very, very important in all these issues of cancer and cancer recurrence. That's why I always ask my patients to join this prostate program. So it's all about the balance. Just like anything else in life, management of prostate cancer is also about the balance. So that concludes my lecture. I've tried to make it as short and as sweet as possible. Now the second part of this webinar is much more difficult. This is trying to answer some of the very difficult questions that you guys have posted. Now, I must emphasize that the answers I'm going to give are going to be quite general. They're not going to be specific for any one of you. Because to answer specific questions, you really have to talk to your caregiver, your doctor, or your oncologist, or pathologist. And some of the questions are really very high-end questions, So some of you may get lost and don't understand what I'm saying. But it doesn't matter because it is only meant for the guy who asked me the question, because I'm the prostate cancer survivor group. There are people who are just newbies who just introduced prostate cancer. Then that they're old, then they are the old warriors who have been around for a long time and their knowledge of prostate cancer is much higher than the rest of you. The answers may make sense to some of you, but not all of you. So don't worry. Now we go to the answer and question and answer session. So you all have asked a lot of questions. And I've tried so I've tried to kind of organize the questions into the various components. Okay. So people have asked me questions about detection of prostate cancer. Is mpMRI needed? If I have prostate cancer, which initial treatment should I choose? Surgery or radiotherapy? Of course, the main topic is recurrence. That means the PSA comes back after your initial treatment. Whether you went for surgery or radiotherapy, the cancer comes back. That's called PSA recurrence, or so-called biochemical recurrence, BCR. They both mean the same thing. PSA recurrence or biochemical recurrence. There have also been a couple of questions on PET scans. What are the costs of all the different scans? There have been one or two questions on hormonal treatment and what has been the effect of this COVID pandemic on prostate cancer survivors, and if the vaccine is finally discovered, should prostate cancer survivors get this vaccine when it is available? Okay, so let's go to the first question: is detection of prostate cancer. So this is the usual way in which prostate cancer is detected. You go along and have a PSA and someone says, hey, your PSA is raised. You go and see the urologist. He does a rectal exam and says, well, I think you should get a biopsy. And so the prostate biopsy, the way that we used to do it, it was a transrectal prostate biopsy, meaning both the ultrasound and the needle that we use to take small pieces of prostate tissue is introduced through your rectum. We take some pieces of prostate tissue, we send it off to the pathologist. The pathologist looks at the tissue under a microscope and she will give you a reading. Do you have prostate cancer or not? If you have prostate cancer, what is the kind of prostate cancer? Is it a low risk cancer, Decent 6? Is it an intermediate cancer, Decent 7? Or is it a high risk cancer, Decent 8 and 10? So this is the usual way in how someone finds out that he's got prostate cancer. Now recently, over the last 5 years or so, we have introduced multi-parametric MRI into this cycle. So multi-parametric MRI is a special kind of MRI. You have to go through this round circular thingy and it will give you a picture of your prostate gland. So this round thing, this round orange or apple thing is your prostate gland. You can see up here, there is this dark spot in the prostate. So when the urologist looks at the spot, he'll say, aha, this spot looks bad. So when he takes a biopsy, he will try and target this area more. Of course, he's going to also take biopsies from this other area, but he's going to concentrate his needle on this. And now the way that we do our biopsies, we have changed it slightly. Although the ultrasound still goes into your rectum, the needle doesn't. The needle goes through your skin, and that's called a transperineal biopsy. And the reason why we like to go to the skin now is because the rectum is a dirty area. So if this needle were to go through the rectum, there is a slightly higher chance of infection. So if possible, we would like to do it transperineal. But transperineal means you have to go under general anesthetic, and it's a much more costly way of doing a biopsy. So in the majority of cases, a lot of hospitals, they still do it through the rectal. So one of the questions was, why should I get a MRI before biopsy? Because what is? So there have been an MRI before you go for the biopsy. Depending on the result of the biopsy, maybe you may not need to do a biopsy. Maybe the radiologist will say, look, his MRI doesn't show anything. Maybe he doesn't need a biopsy. Suppose the MRI says, yes, you do have to go for a biopsy. Now the radiologist can do the biopsy much more accurately because he knows where to put the needle. If after the biopsy you are found that you do have prostate cancer, you still will need to do an MRI anyway before the treatment. So whichever way you look at it, it's better to do the MRI before the biopsy because that is actually the best time to do the MRI. Once you stick a few needles into the prostate, the pictures become a bit fuzzy because every time you put a needle, you cause a bit of bleeding in the prostate. Whereas if you do an MRI, what we call a virgin MRI, before anybody has done anything to your prostate, you get the best result. So MRI before biopsy has now become the standard in a lot of countries. MRI has got no radiation risk. The only thing some people worry about is because you have to go into this tunnel-like thing here, some people are claustrophobic. They're scared to go into very narrow spaces. And those people, if they're claustrophobic, you can receive either some IV sedation or you can even be under general anesthesia. So to become comfortable when you're going for the MRI, you won't feel so anxious. Now, although, as I said, mpMRI before biopsy has become the standard in many countries, it is not widely practiced in coagulation public hospitals. And this is just purely because of logistic reasons. Not enough MRI machines, not enough experienced radiologists who can do this prostate MRIs, long waiting times, long waiting lists. So we go on to the next series of questions. Now that you've been diagnosed with prostate cancer, of course, the next question is going to be, which treatment? Do I go for surgery? Do I go for radiotherapy? This is the perennial question everybody asks you. So, you should consult your urologist. You should consult your oncologist. Get an opinion. If you're not happy with the opinion, get a second opinion or a third opinion from another oncologist or another urologist. You can ask other patients, other prostate cancer survivor patients, what has their experience been. So basically, before you decide, you must do your homework. Overseas, they have special conferences, not for doctors or not for oncologists, but for patients. For example, you look at this, the 2019 Patient Conference on Prostate Cancer. Can you believe it? It's a conference for patients. It's a national conference for patients, families, caregivers, healthcare professionals, patient advocates. So these are the kind of conferences that you should go to. And especially now with this COVID thing, I'm sure a lot of these conferences are now available on Zoom, available on YouTube, where you can get different opinions. And because they are for patients, the language in which the conference is done is more suited to the layman, not suited to the doctor with a lot of medical terminology which you don't understand. So when you ask which treatment is right for me, when you talk to the specialist, you must ask the right question. You must ask, hey doc, what are the chances of cure with this treatment? What are the chances of cancer recurrence? What are the side effects possible with this treatment? Does one type of treatment preclude another? What I mean by that is, suppose I take surgery, can I then do radiotherapy? Or if I do radiotherapy first, can I come back and do surgery? That's what I mean. Okay? And if I get a recurrence, what kind of follow-up treatment do I need? So these are kind of the questions you should ask before choosing. For instance, if someone comes and asks me, I want to go for surgery, can you tell me what will happen after surgery? So I use a cancer prediction calculator. This is an online calculator which has been developed by the Memorial Sloan Kettering Center. This is one of the big cancer centers in New York. So it's an online calculator, an example of artificial intelligence. So on the left-hand side, I put in all the information from the patient. For example, this patient, his age is 63 years old. He came to see me with a PSA of 19. I did a biopsy for him. He had a Gleason 7. Okay. When I did a rectal examination, I thought he had a little bit of hardness in one side, so I put there T2A. That's my assessment. Okay. And then I took 7, 1, 7, 8, 9, 10, 12. I took 12 cores. Usually there's a standard to take 12 cores. The number of cores which had cancer was 5. The number of cores which were cancer negative was 7. So you have to put in all this information into this computer. It's an algorithm, You put all this information into this computer. You click the enter button and out pops the results on the right hand side. So this right hand side is a prediction. It is not absolutely 100%. It is a prediction. So I can tell my patient, I can tell my 63-year-old patient, if I were to operate on you, there is a 25% chance that this cancer has already gone to your lymph nodes. There is a 16% chance this cancer has spread to your seminal vesicles. That means I can tell him even before I do the surgery what you can expect to find after the surgery. And then this tells you what is the chance that your PSA is going to come back years after the surgery. So from here, I can tell my patient the chance that your PSA is going to come back 5 years after surgery is almost 70%. It's the opposite of this. 5 years, you have a 70% chance your cancer is going to come back. In 10 years, there's an 80% chance your cancer is going to come back. That means your PSA, you're going to get a recurrence. This one tells you, are you going to die of prostate cancer? This one says, at 10 years, you have a 99% chance you will still be alive. You will not die from prostate cancer. You may get recurrence, but you will not die. Even 15 years after surgery, because this calculator is only for surgery, 15 years after surgery, you still have a 99% chance you will still be alive, although your cancer may come. So this is the kind of information that the patient would like to know before he goes for surgery. What is the likely outcome? What is the likely outcome of cure? What is the likely outcome that the cancer can come back? So these are some of the things that the specialist can try and inform you. So Generally speaking, what kind of patients will a surgeon not operate on? And say, I think you better go and see your radiotherapist. Okay? So patients who are not fit, patients who've got a lot of heart condition, lung condition, diabetes, previous operation, patients who are very obese, patients whose BMI is 30 and above, they are patients who are difficult to operate. Older patients who have a life expectancy of less than 10 years. That means to say, if this patient sitting in front of you, you think he is not going to be, he's not going to be around in the next 10 years, then probably you think, what's the point of operating on him? He might as well go and have radiotherapy, which is a much lesser form of treatment. What about the cancer? Now, prostate cancer, which has spread into the bladder, or if your MRI shows very, very large lymph nodes, these are the kind of patients with the surgeon might say, look, I think you better run over to the radiotherapist because your cancer looks pretty advanced. And the last group of patients that surgeons won't operate on is patients who have already gone for radiotherapy and then they get a cancer recurrence and they come back to the surgeon and say, can you take off my prostate? Now, these kind of patients, it's very difficult to operate on patients after you've gone. So these are some of the patients who the surgeon may say, look, I think maybe radiotherapy is a better bet for you. Now, there was a question someone asked me about life expectancy. What do you mean by life expectancy and how do you know? So I went along to this World Health Organization table. I put in there life tables by country, Malaysia, and their latest estimation, latest life expectancy was done somewhere around 2016. And these are the age groups. So if you are somebody in this age, if you are between 60 to 65 years of age, your life expectancy means how many more years are you expected to live is about almost 19 to 20 years. If you are a Malaysian male and you are between 65 to 69 years, you have about 15 years left to live. And it goes on like that. So of course, the older you get, your life expectancy gets less and less, very logical. Now, if you are very healthy, you can add 50% to this. That means to say, if you are, say, somebody of between 65 to 69 and you have 15 years, but you're very healthy, you can add another 50% of life expectancy. If you are very unhealthy, you must minus 50%. So as I said, surgeons will not really operate on people whose life expectancy is less than 10 years because the advantage of surgery is lost if you only have a life expectancy of 10 years. So these patients, if your life expectancy is 10 years and less, maybe it's better you have radiotherapy. Now, what about radiotherapists? Will radiotherapists give radiotherapy to everybody? No. The radiotherapists, sometimes they will decline giving radiotherapies. And I have had patients who are referred from the radiotherapist to say, well, I don't think this guy is suitable for radiotherapy. Can you please review him and see him and see whether you can operate on this guy? Okay? And these are all patients of mine, patients who went to the radiotherapist and came back to me. Prostate cancer, which is pressing onto the rectum. Some prostate cancers press onto the rectum and give problems of passing motion. And here the radiotherapist is a bit scared that if you were to try and give radiotherapy to the cancer, he will also give radiotherapy to your rectum and cause a hole in the rectum. So this kind of patients, they say, better to go and see the surgeon. Particularly with diverticular disease. Diverticular disease means people already having problems with the colon and rectum. People already having some problem. Because when you give radiotherapy, some of the radiotherapy will also hit the colon and rectum. So if you already have some disease in the colon and rectum, radiotherapy may not be a good choice. Patients who come and see the radiotherapy, where they already have a catheter, cannot pass urine, they are on a catheter. These are not good, not really the ideal candidate for radiotherapy. Have already had radiotherapy to the pelvis before for other things, maybe for bladder cancer. So the amount of radiotherapy that you can give to a patient is limited. If you've already had previous radiotherapy, the radiotherapist is not sure how much more radiotherapy he can give you. If you give too much radiotherapy, you will get radiotherapy overdose and get a lot of damage to other organs. And then I had a patient who went to Subang Jaya Medical Center, started radiotherapy. He started the radiotherapy, and after I think 3 sessions, he decided, I'm okay, I don't want to go for radiotherapy, and he skipped his radiotherapy. Then his PSA started to go up. And then he decided he wanted to go back and have radiotherapy. And the radiotherapist said, no, you can't do that. But radiotherapy, and then you come back for no more radiotherapy. They cannot calculate the dose anymore. So this patient came back to us and we operated on him. There are other group of patients who may not like radiotherapy, because when you do radiotherapy and you have some high risk cancer, that is a recent 8 times 10, the radiotherapist will also give you hormonal therapy with the radiotherapy. Some patients don't like the side effects of hormonal therapy. So because they don't like the side effects of hormonal therapy, they prefer to have surgery rather than radiotherapy. So these are the kind of issues that you think of, whether you want to go for surgery, you want to go for radiotherapy. You have to do your homework. You have to talk to the oncologist. You have to talk to the radiotherapist. And then you have to make which kind of treatment is good for you. Now, this is a question on PET scans. So the full name for PET scan is known as the Gallium 68 PMSA PET CT scan. This PET scan is the new kid on the block. It's only been available in Malaysia over the last couple of years. Very expensive, much more accurate than CT scan and bone scan for detecting metastasis. Metastasis means cancer which has already spread out of your prostate into the lymph nodes, into the bone, into the lungs. Okay? It's quite a safe scan, very minimal radioactive risk, and does not affect your kidney function. However, it has radiation. Unlike MRI, MRI is a magnetic kind of machine. There's no radiation. Whereas PET scans, there is a radiation exposure. So if I give you an example, if you go for a chest X-ray, the amount of radiation exposure is 0.1 millisieverts. If you go for a CT scan, it is 10 millisieverts. If you go for a PET CT scan, you are getting a radiation of 25 millisieverts. Now, the American Institution of Radiology has recommended that a lifetime exposure, you should only get 100 millisieverts. So if you go for 4 PET scans, you have already reached your lifetime exposure. So all these scans that you go for, there is some radiation exposure, and you have to decide how many scans you want, when is it beneficial for you to do a scan. So it's not these scans are not just meant to be done, willy-nilly anytime you feel you want to do a scan. Now, PET scans, when do you do a PET scan? The main reason to do a PET scan is for patients who have a PSA recurrence after initial treatment. That means you go along and you have your surgery or your radiotherapy, you're quite well for some time, and suddenly the PSA starts to go up. And that is the time to do a PET scan. This is the main indication. However, someone has asked me a very difficult question. Why can't we get a PET scan up front? That means before I decide I want to go for surgery or radiotherapy, why don't I do a PET scan? Now, it's a very controversial and very difficult question because we don't know the answer. Currently, the answer is no. The current answer is no. You don't do a PET scan before you decide whether you want to go for surgery or radiotherapy because we don't know whether it's going to be beneficial for you. Let me give you an example. Okay? Give you an example. So here's this man here. He has got localized prostate cancer. That means he did a CT scan, did a bone scan, and both are negative. No cancer in there. So because he's got localized prostate cancer, of course, he will decide, do I go for surgery or radiotherapy? After surgery or radiotherapy, you follow up your PSA, and after a few years, if you were to get PSA recurrence, means your PSA comes back, also known as biochemical recurrence, then only you get your PET scan. And depending on what the PET scan says, you can either go for radiotherapy around your prostate or go for hormonal treatment. And maybe later, if the PSA still doesn't respond, you go on to these higher drugs, Radiotherapy, enzalutamide, chemotherapy. Okay? So from here, it takes years, takes maybe 10 years for you to go from here to here. So this is the normal pathway. You have prostate cancer, you do CT scan and you do bone scan. If you have localized prostate cancer, you decide surgery, radiotherapy, then you just follow up your PSA. If your PSA comes back, you do a PET scan, and depending on what the result of the PET scan is, you can have radiotherapy to the lymph nodes, or you can go on to hormonal therapy. And hormonal therapy again will last you for a few years before you may have to go on to other kinds of treatment, which is abiraterone and enzyme. So now the question is, if I have localized prostate cancer, shall I do a PET scan first? This is not the recommendation, but a lot of people say, let's do a PET scan. Now the problem is, if the PET scan, just suppose it shows a few spots outside your prostate. That means to say you have got metastasis. That means your cancer has already gone out of the prostate. But only a few spots. So this is what we call oligomets. That means you've got metastasis, but very small. What do? Do you still continue along this recommended pathway? Or do you say, look, I've already got metastasis, I don't want to go for this, I will go straight for hormonal treatment. And of course, hormonal treatment will last you for a number of years before you have to go back to abiraterone and enzalutamide. So there are two pathways here. See, this is this pathway here, this is this pathway here. This pathway is the gold standard recommended pathway, because you can have many treatments, before you end up with the big guns. So it's like playing poker. Here you got many cards you can play. But if you go along this pathway, you've only got a very few cards to play. So this pathway, we don't know, is this pathway better than this pathway? We don't have information. That's why normally we don't ask you to do a PET scan before you decide on surgery. But this field here is a changing field. Every day we get more information. So at the moment now, this is our standard pathway. This one is an alternative pathway. We are not sure, is it the correct pathway? We are really not sure. And as we get more information, then we do. So for the current knowledge we have now, the PET scan is only done here when you get biochemical recurrence or you get PSA recurrence. That is the time to do the PET scan. This pathway here, we are not sure. Okay. That was a very heavy slide. So we'll go on to something a bit more easier. Costing. People always ask, what is the cost of all these expensive scans? So I can only give you the costing in some way. Multi-parametric MRI, upward of 2007. If you are somebody who's very claustrophobic, you need to have some sedation. Just sedation, it is an additional 1,000 to 2,005. If you're a guy who's really very anxious and need to go to sleep with general anesthesia, then it's another additional 2,000. Bone scan costs about 768. Don't ask me why you got $2 discount here. But if you get a government referral letter, you can get it cheaper for 650. PMSA PET scan, the price now has come down. It used to be 6,000. Now it's about 5,000. So this is the kind of costing that you can expect if you come to a private hospital. Okay, now we come to the very difficult, topic of PSA recurrence or biochemical recurrence, which everybody is scared about. So this means PSA recurrence after your treatment. Your treatment could be surgery or therapy. And we know biochemical recurrence occurs in 30 to 50% of patients, sometime during your follow-up. Like for instance, here you can see this graph of one of my patients. This patient of mine was high-risk prostate cancer. He was a young man when he came and saw me somewhere in 63. He had a Gleason 8, high-risk prostate cancer. When he came and saw me, his PSA was 25. Okay. So he had treatment. Your treatment here can be anything, can be surgery or radiotherapy. He decided to have surgery. So his PSA came down and was down for a long time. For what? 1, 2, 3, 4, 5 years. then it started to go up. Called PSA recurrence or biochemical recurrence. It can happen to anybody, but it's more common in those people who have got high risk prostate cancer, intermediate risk prostate cancer. Someone asked me, his PSA is 0.08, he said, 8 years after robotic surgery. We asked, is it likely that I will get? So of course, in his case, because he has remained low PSA for so many years, his chances are less. Less meaning maybe less than 5%. But we have had patients who 15 years later still have PSA recurrence. So PSA recurrence can happen anytime. That is why after you've had your initial treatment, you have to do your PSA regularly for the rest of your life. So what happens? I mean, the talk I gave just now was how to prevent recurrence, isn't it? Diet, exercise, special foods, and all those kind of things. What happens if you do get recurrence? Now, the first thing is people ask me is, hey doc, how can I get that? You've already removed my prostate. Or, you know, if he goes to the radiotherapist, he said, you've already radiotherapy to my prostate. How can I get recurrence? I don't know. The reason why the cancer comes back after treatment, the reason why it comes back is because some small cancer cells, they already have escaped out of the prostate before you've gone for the treatment. These cancer cells are so small, you know, they're like this coronavirus, you can't see it, it's so small. Even the scan, even the PET scan can't see it. So these cells have already quietly escaped through the bloodstream and gone to other parts of your body. But these cancer cells are very small. They just keep quiet. They don't do anything. And then slowly later over the years, they will start to grow. And when they grow, they will produce PSA. And then the PSA level in your blood will go up. And that's how you get a PSA or biochemical recurrence years after your initial treatment. It's not that the treatment wasn't effective, but these cancer cells have already escaped from your prostate before your treatment. So, what should your PSA be after your surgery or radiotherapy? After surgery, your PSA should be less than 0.2. That's what Kwan-Seng was saying. Oh, don't worry, your PSA hasn't reached 0.2, you can relax. Only when as long as your PSA is less than 0.2 after surgery, you don't have to do anything. Just wait. And after surgery, this target PSA is reached very quickly. Within 2 months after surgery, you already have your idea. You already have your answer. Have I reached my target PSA? So that's for surgery. For radiotherapy, they don't really have a definite value of PSA. They just say the lowest PSA or the nadir PSA. It could be 0.2, it could be 0.3, it could be 0.4. They don't really know. And this nadir PSA is not reached immediately. It sometimes takes somewhere between 1 to 2 years after radiotherapy to reach that nadir PSA. Okay? So this is the kind of PSA values you're looking at. And if your PSA value goes more than that, then you have what we call PSA recurrence or biochemical recurrence. So, of course, the patient, of course, gets very disappointed because his PSA has come back. He gets very anxious. He says, oh, now my disease is active. I'm dying. I must be treated immediately. If not, this cancer is going to spread. These are the usual thoughts that goes through a patient's head and the PSA. Somebody also asked me, I'm on Cialis. Can Cialis cause PSA recurrence? For those of you who don't know, Cialis is something to treat your erectile dysfunction. And my answer is Cialis does not cause PSA recurrence, so you can continue to take your Cialis. So PSA recurrence, the first thing is, you know, as I said, prostate cancer is a very, very slow disease. It takes years, you know, for it to progress. So don't panic. You're not alone. 30 to 50% of men who have had treatment for prostate cancer are going to get a recurrence. And most men with PSA recurrence continue to live for many, many years. PSA recurrence just means that you have to go for more tests, you have to go for more scans, and probably you will have to go for more treatment. But you will still live long years. So PSA recurrence means there are some cancer cells somewhere in the body. You don't know where. Patient, however, is usually very well. Patients are very well. They have no pain, no swelling. All they have is a blood test which says your PSA is Otherwise, they are very fit, they're very healthy, they do everything they normally do. They don't feel that they have cancer. So if you have a PSA recurrence, this is the time to do some scans to see if we can detect any cancer spread. This is the time to do all these scans. And what scans? Bone scan, CT scan, MRI scan, and as I said, this new kid on the block, PET scan, which is supposed to be the most accurate. Okay? So your prostate is somewhere around here. Prostate gland is here. You do the scan. You want to know, is this cancer? Is this cancer just spread somewhere around the prostate? That's called localized. Or has this cancer gone outstation? Has it gone elsewhere? And that is called metastasis. Okay? If the cancer is within the pelvic area, means around this area here, it means local. You're a local boy. Has it spread anywhere else? It means to say, if you had radiotherapy, this local may be still inside the prostate because the prostate is still there. If you've had surgery, of course, the prostate is not there. So this local means just outside the prostate. Or the scan can show that the cancer has now gone outstation, or what we call metastasis. It has gone to other areas, lung, brain, bone, abdomen. So that's the idea of doing the scan, to try and work out where is this cancer now. So the treatment for prostate recurrence depends on where the cancer is, of course. If your recurrence is local, just around here, so you can go for local treatment. If you've had, surgery before, you can add on some radiotherapy. Surgery after radiotherapy, of course, is very different. If your cancer has gone outstation, metastasis, lots of metastasis, then you have to go on to for hormonal treatment. Now, I've put here in very small letters, oligometastasis. This is the new thing that we are finding now with the PET scan. New thing. That is to say, you have metastasis, but it is oligo, very, very small spots. You've got one spot here, one spot here, one spot here. In these kind of few spots, instead of going for hormonal treatment, which treats the whole body, you can go for what is known as SBRT. This also is a very new form of treatment. You may have heard about it. It's called gamma knife, cyber knife, Beacon Hospital. This is a new form of, even I think in University Hospital, Manisa is doing it. SBRT. It's a very new form of treatment. This is for people who have got metastatic disease, but only a few spots. So instead of going for hormonal treatment, some people may suggest for you to go for SBRT. Just give radiotherapy to the few spots. It's like spot welding, Just give a few areas. This is something new. That's why I put it in the small letters. I don't want you to get confused. So if your scan says you've got cancer just in the pelvis, either in the prostate, your radiotherapy, or just outside the prostate, you can go for local treatment. After surgery, if your cancer recurs, you can go for radiotherapy to the pelvis. With radiotherapy, you can get a 50% cure rate. 50% of people, the PSA will go down and remain low. Another 50%, it may come down, but it will go up again. So if it goes up again, that 50% of people will have to go for hormones. If you had radiotherapy as your initial treatment, and now you have local recurrence, of course, you can say, let's go and take out the prostate, because the prostate is still there after radiotherapy. And some surgeons will actually go and take out the prostate. But it is very, very difficult surgery, because, radiotherapy is very difficult surgery, and your continence will not be so good. So most surgeons will be scared to go and operate after radiotherapy. Some surgeons will. So if you cannot do surgery, then you have no choice. You have to go straight to hormones. So the other question that I got asked is, tell us something about hormonal treatment. What does it mean? How do you get it? When should you take it? So this is another very big topic in prostate cancer. You can have an entire lecture on it. Hormonal treatment, there are two ways to get it. The common way is you must get an injection every 3 to 6 months for the rest of your life. A better way, or may I say a cheaper way, a safer way and more permanent way is just to have an orchidectomy. An orchidectomy is a simple operation done under outpatient, no general anesthesia. You make a small cut in your scrotum and just take out the two testes. It's a very safe, cheap, and permanent form of hormonal. So these are the two ways you can have hormonal treatment. How does hormonal treatment work? Hormonal treatment decreases the male hormone in your body. The male hormone is your testosterone. By removing this testosterone, you remove the fuel for prostate cancer. Prostate cancer requires hormone to grow, and that's how it works. However, hormonal treatment does not cure the cancer. It does not cure prostate cancer. It just slows down the prostate cancer, and it reduces the PSA and the growth of the cancer, average about 2 years. So it gives you about a 2-year period, holiday period of 2 years. But the problem with hormonal treatment is it has got many side effects. That's the problem. So some of the side effects of hormonal treatment, hot flushes, your muscle become weak, your bones become weak, easier to fracture your bones. Some people, not all people, get some tiredness, get some mood changes, memory loss. Metabolic syndrome. Metabolic syndrome means people who, because of hormonal therapy, put on weight, increase their blood pressure, they have a higher chance of getting diabetes, and their cholesterol levels go up. And all this can also cause heart disease. And of course, the moment you take hormonal therapy, you can forget about sexual function. Your libido, erection, everything goes off. So in younger men, although they have a lot of side effects, this is the one that they fear the most, loss of sexual. So because of all these effects of hormonal therapy, it sounds like a good idea to control your cancer, but you have to take into account these side effects. There was another question that I got from one of your members: how to decrease the risk of weak bones, or what we know of osteoporosis, and risk of fracture. So anybody who's taking hormonal treatment should be also taking calcium 1000 milligrams a day, and should also be taking vitamin D3, about 400 or 1000 international units a day. And you should also get a baseline DEXA scan. A DEXA scan will show you what is the condition of your bone at the baseline before you even go on to hormonal therapy. If the DEXA scan shows that even before you take hormonal, your bone is already a bit osteoporotic, then in addition to calcium and vitamin D, you should take additional medications. And these are some of the additional medications you take. You can take oral medications, Phosphomax, because in fact this patient asked me about Phosphomax. Okay? Or you can take an injection, denosumab or zoledronic acid once a year. Phosphomax you've got to take every day. Whereas injection, you can just take it once a day. And if you're going to take any of these medications, you should get a dental checkup, because these medications can cause what is known as osteonecrosis of your jaw if you were to go and do any dentist work. So it's a good idea before you start any of these medications, get a dental checkup and do any dental work you need. To pull out your teeth or do your orthodontics, do all this before starting these kind of medicines. These medicines are okay. These are the standard medicines that you should take if you are on hormonal treatment. Okay? So this is a picture of David. David is supposed to be the ideal man. This is a sculpture of Italy. So if you were to give David hormonal treatment, this is what will happen to him. Okay? It's of course an over-exaggeration. I'm just trying to prove the point. If you take hormonal medication, these are the things that may happen if you do not take. So because of these side effects, we try and delay starting hormonal treatment for as long as possible in the majority of patients. And this is called delayed hormonal therapy. That means to say, no need, you just follow your PSA, it's not increasing very fast, your cancer is progressing very slow, you can wait before you take hormonal therapy. However, some patients, we might say, I think for you, you better take early hormonal therapy. And these are the high risk. So how do we know whether you are high risk, you must take early, or you're the low risk, you can? PSA doubling time. PSA doubling time is one of those key things that we look at. And that's why we ask you to do your PSA regularly every 6 months. So you have a list of PSA levels, and you can calculate how fast is your PSA time, how fast does it take the PSA to double. PSA doubling time is less than 10 months. That puts you at the higher risk of the cancer progressing quickly. Therefore, we might say, well, if your PSA doubling time is less than 10 months, maybe you should consider taking early hormone rather than wait to take the hormones later on. So, generally speaking, who are the patients who we think should start hormonal therapy early? This will be the high-grade ship of high-grade cancer. Those who get the PSA recurrence early, within 1 year of your surgery or radiotherapy, your PSA starts to go up. And as I said, those whose PSA doubling time is quite short. The PSA doubling time is less than 10. In these patients, maybe you should go and start your hormonal therapy earlier. So in these patients, your benefits may outweigh your side effects. This actually is one of the patients also. One of the patients asked me this question. So this refers to one of the questions. He had localized prostate cancer. He went for surgery. He had PSA recurrence. Then he went for radiotherapy plus 3 months of hormonal therapy. The PSA at the moment now seems to be controlled, but maybe it's rising very slightly. So the question he wants to ask me is, Doc, I've already done my initial treatment. Now I've got biochemical recurrence. That is, the PSA went above 0.2. He went for radiotherapy to the pelvis plus 3 months of hormone. PSA appears to be controlled, but maybe going up slightly. What should I do? So I told him, you should do the PSA every 3 months, and you can calculate your PSA doubling time. If you want, and it's available, this is the time to do a PET scan. That expensive scan. This is the time to do it because you've got PSA recurring after primary treatment. You've got PSA recurring after radiotherapy. Maybe this is the time to do a PET scan. So you've got 3 options. If by calculating your PSA doubling time, it is very short, maybe about 6 months, let me see, he's probably somebody who you want to start hormonal therapy early. If on the other hand, his PSA doubling time is very long, maybe 10 months, 11 months, 1 year, this is the kind of patients you say, you don't need to start hormone straight away, wait and see. And then if he is able to do a PET scan, that means he's got the finances to do a PET scan. And the PET scan in this case shows the metastasis that he has outside the prostate is very small, oligometastasis. Then he may be a candidate for the special form of treatment, I said, SVRT, gamma knife, cyber knife, where instead of giving hormone, you just give this kind of special kind of radiation just to the small areas. So I know it's a very complicated kind of a treatment. Last time we never had PET scan, so this was not here. We just wait and see. Give hormone therapy early or give hormonal therapy late. That was the only answer we had to. No question that happens. One more question. Somebody asked, Aerobic, can I take smaller dose? Okay. So I went to this NCCN. This is the National Comprehensive Cancer Network, one of the big cancer organizations in the US. And this is their latest recommendation, 2019. Okay. They say the usual dose of RD is 1,000 milligrams after an overnight fast. That means just before breakfast. But they also say an alternative is just 200 milligrams after a low-fat breakfast. And this, of course, is because cost saving. However, this is not recommended by the pharma company. Because pharma company will make money, so they don't recommend this. But at least you have some recommendation coming from a very reputable cancer institution that you can try this if cost is a problem. And the last question for N, someone asked me, COVID pandemic and prostate cancer care. How has the COVID pandemic affected prostate cancer care? So, of course, during the lockdown period, all surgeries, chemotherapy, immunotherapy, radiotherapy was all postponed. Now, services are restarted. But because of the long waiting, but there's a long waiting time in the public hospitals because we have a big backlog of cases which have been waiting for 4 months. So the waiting time for all these treatments will be staggered. And also, clinic visits to public hospitals may also change to a new norm, where patients are interviewed by phone rather than coming to the clinic. That means, you come to the clinic, you take your PSA, the doctor will review your PSA and see. If your PSA is normal or stable, you don't really have to come to the clinic to see the doctor. You can just interview over the phone, ask you, how is your continence, how counseling asks, how's your continence, how's your PSA? We can do this kind of reviews over the phone without patients coming to the current cancer patients, prostate cancer patients who are undergoing chemo or immunotherapy, they are still at risk of COVID, although the COVID appears to be abating. And of course, they should take the proper precautions when they are taking this form of treatments. There are also several government, social, and NGO hotlines to help out cancer patients with social and mental issues, financial issues. You can approach these hotlines to try and help out the problem. And of course, prostate cancer survivor groups, they can help out their members for any kind of problems they have. And COVID vaccine, when we finally get it, I don't think it's going to be a live vaccine. It's going to be a dead vaccine. So I think it should be okay for most prostate cancer patients and survivors to get this vaccine. I think with that, I will end my talk, and I will have to leave you guys because I'm late for my next appointment. I hope you enjoyed this talk, and I'll see you again another time.